Welcome back to House Healthcare. Sorry about that abrupt end. We were having technical difficulties, which we believe have been fixed. So I'm going to start over since I'm not sure when we lost sound, but we will be taking up Act 85 of 2022 right now, which is, I think, maybe the third bill we passed for COVID flexibilities over the last 3 years, where we put some flexibilities in place to help our healthcare system manage the pandemic. These flexibilities of Act 85 expire on March 31st. And before we left, I just want to bring all the new members up to speed. So before we left in March 2020 for what we thought was, 2 weeks or so, we happened to, in the healthcare committee, have several advocates with us at the time who are still with us now. And our chair at the time said, let's all come together and work on what we think will be needed for what we don't know is about to happen. And that group of healthcare coalition providers were incredible, and were incredible through the last 3 years and have done tremendous work for us. So thank you. But now they're back to walk through with us what they would still like extended and or potentially made permanent based on what we've learned over the last 3 years. So that's the basis of what we're doing today. So Legislative Council will be with us to walk through Act 85 provisions that the coalition would like us to continue or make permanent, either, extend for a year or make permanent. We're not necessarily going over the provisions that they've suggested we let expire. If you do have questions, we'll see what we can do with those, but we're going to focus on what they would like to continue. So Jen will walk us through that chart, answer our questions around the language, and then we'll turn to the stakeholders to talk about the policy behind the request. Okay. So Jen, I'll turn it over to you.
Thank you. Good morning. Jen Karby, Director and Chief Counsel of the Office of Legislative Counsel. And so what I'm going to put up, there's 2 documents, I think, under my name. One of them is this chart that I've been updating each time there's a new act, extending some of these provisions so that you can see what the provisions are, what the recommendations are from stakeholders who have weighed in so far, and when the provision is supposed to expire under existing law so that you can consider the changes you want to make. So I will put that up on the screen and we will walk through it. And the other document is language.
Right. So let me just clarify. We don't have a bill on the wall for this. So this would become a committee bill.
That's right.
Which would be the first one we would do. So, okay.
All right. So we'll start by looking at the chart, and then we can look at the language that reflects so far what is in the chart. So what this is doing, if you look in the left column, we have the act or acts that enacted or amended this language, and what section or sections those were. A summary of the provision, the highlighted date under duration in existing law is the current provision, but if you're interested in what the past history has been of extensions, that's in there as well. And then what the recommendation is or are from stakeholders who have weighed in, and then there's a column for this committee to make some decisions. So I will probably mostly start with the section numbers from the original Act 91, which was the act that I think of as the On the Way Out the Door Act in 2020. So Section 1 of that act had directed the Agency of Human Services to consider modifying existing rules or adopting emergency rules to protect access to healthcare services, long-term services and supports, and other human services, and to consider the importance of the financial viability of the providers who rely on public funding. That was originally enacted to be in place during the COVID-19 state of emergency. It has been extended a number of times, most recently to stay in place through March 31st of this year. The Provider Coalition, which is the group that the chair was describing and who I think you will hear from, are suggesting that this provision be allowed to expire. So it's been extended a number of times. It sounds like the recommendation is this is no longer needed after March 31st, and it should be allowed to expire. The Board of Medical Practice has also weighed in on a number of provisions, although in some cases they expressed no opinion if it was an issue that was really outside of their purview. And I think you'll be hearing from the executive director of the Board of Medical Practice in a bit as well. Two of the sections are grayed out. That's just to indicate that they've already expired. Nobody's talking about extending them. So section 2 was around some provider taxes that expired on its own terms, and nobody has proposed extending it. Section 3 from Act 91 had language that said in order to protect non-healthcare professional employees from COVID-19. So there's a lot of provisions in state and federal guidance and law around protecting healthcare professionals. There was concern about protecting non-healthcare professional employees from COVID-19 who are working in healthcare facilities and at human services providers. So it required those facilities and providers to follow. Initially, it was health department guidance that was changed last year to be state and federal public health guidance regarding measures to address employee safety to the extent feasible. That provision had been extended a number of times, currently through March 31st, and the Provider Coalition says to allow this to expire. The Board of Medical Practice expressed no opinion. So for these where there's the proposal to allow them to expire, when we look at the language, they're just not reflected in the draft. But we can pull up the language if anyone wants to see what had been in place. Section 4 allows the Secretary of Human Services to waive or permit variances from the agency's healthcare and human service provider rules as needed to prioritize and maximize direct patient care, support children and families who receive benefits and services through the Department for Children and Families, and allow for the continuation of operations with reduced workforce and flexible staffing arrangements. This is currently set to expire after March 31st of this year. The Provider Coalition proposes extending that for an additional year through March 31st of 2024. The Board of Medical Practice does not oppose the extension, but otherwise took no affirmative position. Section 5 allows the Green Mountain Care Board to waive or permit variances from laws, guidance, and standards relating to hospital budget review, certificates of need, health insurance rate review, and accountable care organization certification and budget review as needed, again, to prioritize and maximize direct patient care, also to safeguard healthcare provider stability, and to allow for orderly regulatory processes that are responsive to evolving COVID-19 related needs. That currently is in place through March 31st of 2023. I think it was sort of suspended for a while, but was reinvigorated in last year's act. The Provider Coalition is recommending extending that for an additional year through March 31st of 2024. The Board of Medical Practice had no opinion. Section 6 from Act 91 requires the Department of Vermont Health Access to relax Medicaid provider enrollment requirements and the Department of Financial Regulation to direct health insurers to relax their plans' provider credentialing requirements to allow providers to deliver or be reimbursed for services across healthcare settings as needed to respond to evolving needs, as providers may be delivering services in settings other than where they usually deliver services. This is currently in effect through March 31st of this year. The Provider Coalition is recommending extending it for an additional year through March 31st of 2024. And the Board of Medical Practice has no opinion on that proposal. Section 7 has already expired. It was valid during the state of emergency and was not extended beyond that. Section 8 from Act 91, which has been amended, as you can see, in several different acts since then, directs the Department of Financial Regulation to consider adopting and gives it authority to adopt emergency rules to do a few things: expand health insurance coverage for and waive or limit cost sharing requirements directly related to COVID-19 diagnosis, treatment, and prevention, to modify or suspend health insurance plan deductible requirements for all prescription drugs, and at the bottom, address health insurance coverage of and reimbursement for telephone triage services. That's a brief telephone visit to determine whether an office visit is appropriate. You can see that in 2021, there was a provision that was eliminated dealing with audio-only telephone services, and that a number of those provisions were codified into permanent law, so they didn't need to be extended, and they were taken out of this ongoing session law. So those provisions are currently in effect through March 31st of this year. The Provider Coalition recommends extending the first two bullets, the coverage and the cost sharing for COVID and the prescription drug deductible requirements for an additional year through March 31st of 2024, but allowing the telephone triage coverage to expire. And they can speak to you more about that if you have questions. Board of Medical Practice had no opinion. Section 9 of Act 91 requires health insurance plans and Medicaid to allow members to refill their prescriptions for chronic maintenance medications early so that they can maintain a 30-day supply of each medication at home. If you remember back to early days of the pandemic, in particular, it was difficult for people to get out to the pharmacy, or people were limiting their outside visits. So this was trying to make sure that people always had their maintenance medications at home. This provision is currently in effect through March 31st of this year. The Provider Coalition recommends allowing it to expire, and the Board of Medical Practice has no opinion. Section 10 is a provision that already expired. It was in effect through June 30th, 2021, and no one has requested extending it. Similarly, Section 11 also has expired on its own terms. Section 12 of Act 91 would allows currently a healthcare professional to authorize renewal of an existing buprenorphine prescription without an office visit. And this is in the language, it's to the extent permitted under federal law. This is currently in effect through March 31st of this year. The Provider Coalition wants to make that permanent. So you'll see in the language that we look at this provision, I'm moving it to statute, and it would be codified in the green books and not have an expiration date. The feedback is that in this case, actually the Department of Health, through the Executive Director of the Board of Medical Practice, who may be speaking to this in his testimony. The Health Department supports some form of an extension, but also wanted the legislature to consider perhaps at least requiring a telemedicine visit or some kind of interaction with the provider. So you can hear from the Provider Coalition and from David Herlihy their thoughts on that.
And we will also connect with Human Services on this one.
Yes, for anyone who doesn't know, buprenorphine is typically prescribed to treat substance use disorder, and that is usually within the purview of the Human Services. Section 13 of Act 91 allows the Agency of Human Services to reimburse Medicaid-funded long-term care facilities and other programs that provide 24-hour-a-day services for their bed hold days. These are days where the patient may be in another facility. The example that was certainly contemplated during COVID was in the hospital, and that bed couldn't be filled with another patient but had to be held. This allowed those facilities to be reimbursed for holding the bed those days. Otherwise, under normal circumstances, they would not. And that is currently in effect through March 31st of this year. The Provider Coalition suggests allowing that to expire, and the Board of Medical Practice expressed no opinion. Section 17 of Act 91. We're getting into looking at providers from out of state delivering services in Vermont. So this section deems a healthcare professional who is licensed, certified, or registered to provide healthcare services in any other U.S. jurisdiction. It deems them to be licensed, certified, or registered to provide healthcare services to patients in Vermont. Initially, this had language in it about you doing so using telehealth, which we have now codified through a telehealth registration and licensure process that is being implemented over time. So that language is out of the current draft. We don't need it anymore. And last year's act gave a time limitation. It would have this deemed licensure in effect for up to 6 months for someone from out of state serving on the staff of a licensed facility in Vermont. There was also some language added in a couple of other acts around someone who's providing services as a volunteer member of the Medical Reserve Corps or as part of the staff of a federally qualified health center, and then also added working on the staff of another healthcare facility, so broadened the definition there. It also, under existing law, requires an out-of-state healthcare professional who plans to provide services in Vermont as part of the Medical Reserve Corps or as part of the staff of a facility here in Vermont to submit to the Board of Medical Practice or the Office of Professional Regulation as appropriate given their profession, their name, their contact information, and where in Vermont they will be practicing. And then Act 6 of 2021 also required the OPR and Board of Medical Practice to provide notice to the relevant stakeholders of the expiration date of this provision. So it is currently scheduled to run through March 31st of this year. The Provider Coalition recommends extending it through March 31st of 2024, and their stated rationale was to allow OPR more time to advertise permanent flexibilities and implement for professions beyond nurses. So I'll let them speak more to what they mean there. And they also suggested adding a Board of Medical Practice report requirement due back to you in January of next year on some things that the board is doing or can be doing to expedite credentialing here. So we will look at that language in the draft. I put some report language in the draft. The Board of Medical Practice expressed support for extending in-person practice. There was some additional nuance, I think, to David Hurley's recommendation that I didn't entirely follow, so I will let him speak to it, but I just wanted to note here that there may be some additional nuance to the board's recommendation. Section 18 of Act 91, so that was about, Section 17 was out-of-state providers delivering services in Vermont. Section 18 of Act 91 allows a former healthcare professional, so this is someone who we'd originally referred to them as retirees, but later modified that language to say that their Vermont license, certificate, or registration became inactive not more than 3 years ago, to provide healthcare services to patients in Vermont by telehealth or as part of the staff of a licensed facility after submitting their name, contact information, and where they will be practicing to the Board of Medical Practice or OPR as applicable based on the provider type. There was that same language added in Act 6 of 2021 around serving as a volunteer member of the Medical Reserve Corps or as part of the staff of an FQHC. And Act 69 also added language about working in other healthcare facilities. Act 6 again requires OPR and the Board of Medical Practice to provide notice of the expiration date to the relevant stakeholders to let them know this authority is about to expire before it does. And that language also allows OPR and the Board of Medical Practice to issue free temporary licenses to healthcare professionals whose Vermont license, certificate, or registration became inactive between 3 and 10 years ago. So the first bullet here was around people who had gone inactive within the last 3 years. This is for people between 3 and 10 years. They could get a free temporary license, but allowed OPR or the Board of Medical Practice to impose limitations on the scope of practice as appropriate. So again, as you can imagine, there was concern about whether we would have sufficient workforce to treat all of the people who may fall ill from COVID. And so both of these provisions were expanding the potential provider base. This provision on former healthcare professionals currently expires at the end of March 31st of this year. The Provider Coalition is recommending that provision be allowed to expire, as does the Board of Medical Practice. So for these former healthcare professionals, the recommendation from both groups is to allow that provision to expire. Section 20 of Act 91 said if the director of OPR or the Board of Medical Practice, executive director of the Board of Medical Practice, found that their respective boards could not reasonably, safely, and expeditiously convene a quorum, then the OPR director or the executive director of the board can exercise the full powers and authorities of their respective boards, including disciplinary authority. And they would need to post records of any actions that they took on the website of the regulatory board on whose behalf they took action. That provision is currently in effect through March 31st of this year. The provider coalition deferred to OPR and the Board of Medical Practice. The Board of Medical Practice has weighed in to say they would allow this to expire. It was never really used, and for the board, and remote meetings have become the norm, and there are a number of processes set up in statute to allow remote meetings to continue. So this provision is not necessary. Section 21 allows the director of OPR and the commissioner of health to issue orders governing regulatory professional activities and practices as needed to protect the public health, safety, and welfare. This is currently in effect through March 31st of this year. For those who are new, I think there's been testimony from the former director of OPR, now Deputy Secretary of State, that she had used that authority at least a handful of times during the pandemic. That has currently been extended through March 31st of 2023. The provider coalition deferred to OPR and the Board of Medical Practice. Board of Medical Practice recommends allowing that to expire. And I think you will hear from the Deputy Secretary for OPR position. Section 22 is not time limited per se, but was specific to COVID-19 exposure or positive test. So I've left it in here. This language specified that it is not to be considered the emergency involuntary procedure of seclusion for a voluntary patient or for an involuntary patient in the care and custody of the Commissioner of Mental Health to be placed in quarantine if that patient had been exposed to COVID-19 or in isolation if they've tested positive. And similarly, it is not to be considered seclusion for a child in a residential treatment facility to be placed in quarantine if the child has been exposed to COVID or in isolation if they have tested positive. So again, there's nothing that needs to be done on this. It's specific to COVID exposure or a positive test. Section 26 is around telehealth, and this language, as amended last year, says, to the extent permitted by federal law or guidance on enforcement discretion, it allows the waiver of telehealth requirements in Vermont law relating to requiring the use of a HIPAA-compliant connection if it is not practicable to use that kind of connection under the circumstances. There was some additional language that had been in place around waiving informed consent requirements if it was not practicable to obtain or document them under the circumstances. That language has been removed, so it would not continue. So it would just be this, to the extent allowed under federal law or guidance on enforcement discretion, the HIPAA compliant connection requirement is waived through March 31st of this year. The provider coalition recommends extending that through March 31st of 2024 to remain consistent with federal flexibilities. The Board of Medical Practice does not oppose that extension. There was a expired but now codified provision around boards and professions attached to OPR. Now we are into language that was not in Act 91. Its first appearance was in Act 140 of 2020. And Section 15 of that act allowed the Board of Medical Practice or its executive director to issue to an individual licensed as a physician, physician assistant, or podiatrist in another jurisdiction a temporary license to practice in Vermont until not later than April 1st of this year, and allows the Board of Medical Practice or its executive director to waive requirements, including the scope of practice requirements for physician assistants, but also to impose limitations or conditions when granting the waiver. This provision is currently in effect through March 31st of this year. The provider coalition recommends extending it through March 31st of next year to remain consistent with federal flexibilities. Board of Medical Practice does not oppose the extension, but thought it seemed unnecessary if deemed licensure was extended. And now that we have telehealth registration and licensure, so I will let the director of the board explain more about their position on that. This was a provision first added in Act 178 of 2020. which allowed clinical pharmacists to prescribe a number of medications under clinical pharmacy provisions. There is a sunset on a pharmacist's authority to order or administer COVID tests under a state protocol approved by the Commissioner of Health. This is currently in place through March 31st of this year, and the Provider Coalition recommends allowing this to expire. Although I think OPR may be proposing something ongoing with COVID in another bill in another committee. So they may speak to that.
Good.
Almost done with the chart. From last year's Act 85, there are transitional telehealth provisions, telehealth registration provisions that are kind of our transition process. They're to keep things in place while the new registration and licensure process is being rolled out. So those are currently in effect through June 30th, 2023. The Provider Coalition recommends allowing those to expire when they run out at the end of June. Board of Medical Practice did not oppose, but was concerned there may be inconsistencies with Section 17 of Act 91, which again, I will let David Herlihy speak to. And finally, and mostly for the committee down the hall, but just because you'll see the language in there, there is language that originated in an act from 2020 allowing remote witnesses and explainers for advanced directives. These are documents that people use to express their wishes if they're not able to make healthcare decisions for themselves, and to appoint an agent to make healthcare decisions for them if they're not able to make their own healthcare decisions. So during the pandemic, there were provisions initiated to allow for remote witnesses, since it might be difficult to have witnesses in the same place. This is currently in effect through March 31st of this year. The Provider Coalition, specifically including the Vermont Ethics Network, which is very involved with advanced directives, recommends making this permanent and allowing e-signatures to be used by the principal and remote witnesses. Board of Medical Practice has no opinion, and I'm still working on drafting that language, so it's not finalized in what you'll see. It's just flagged for attention.
Great. Thank you, Jen.
Yes.
So Art and I at the same time asked Claire to print off some copies of the chart. So she made some extras in case anyone would like one. And Mari has a question.
Thanks, Jen. Bottom of page 8, the last row, Act 178, Section 12A. I just want to clarify that it's the pharmacist authority that will be allowed to expire. It's not that the sunset is expiring, therefore making it permanent.
Right. Thank you. Yes.
I did a weird thing there.
Yes, and sometimes we repeal sunsets and then they don't sunset. In this case, I think they're saying allow the sunset to take place.
Okay, thank you.
Yes, although they can clarify if that is not what they're saying. And as I said, there may be efforts to address this on a more ongoing basis in the context of OPR's authority in the Government Operations Committee.
Okay.
Leslie?
I'm sorry, I probably should know this, but could you remind me who is in the coalition?
When the coalition comes to speak, we will definitely have it.
Some of their spokespeople are behind
I
you.
just
And
have no idea
Yes.
who's in that group.
Yeah, definitely. Thank you, Jen.
Yes. Do you want me to put up the language, or do you want to hear from witnesses?
What does everyone want to do? Do we want to hear from witnesses first, or
Yeah, that's sort of a practice question, because I have questions specifically on section 12 and 13, but I don't think they're questions for Jen.
Probably not.
Yeah.
So let's bring the witnesses up to talk about the sections relevant to them, and then we'll go from there. Thank you.
Great. Yes. That'd be important.
So does anyone else need a copy before we continue? Because we won't have it up on the screen, so I apologize. We should have done that beforehand. So
Are there more in the rooms?
Yes, Claire can make
printing
some.
some more.
Thank you, Claire.
Do you want the language?
Yeah, might as well. Thank you.
Do you want to sit up together? How do you want to do this?
You kind of, take the chair.
Okay. I think that might, yeah, I think that might be the best, because I have a
Yes.
feeling we're gonna need to. Do you want me to, I was actually gonna work from our table, not Jen's table. Because there's some detail in there
I
about,
want a copy.
So, well, I could join the Zoom and.
That would be great.
Yeah, sorry, you guys just moved to us a little quicker than I expected.
Yep, nope, that would be great.
Why don't, while you're doing that, should I introduce us?
Yes.
Oh, wait, no, why is that not on here? Oh, it is. No, here. Okay. We met some of us individually. We will explain how we worked collectively also. So on the last very back page, page 6 of our chart, which eventually we could merge.
Which we have online.
Have online
Okay.
and Jill is pulling up, and it is
Okay.
hopefully very similar to Jen's. We just
Okay.
didn't have that yet.
That's fine.
We did our own.
We will make it work. And can you just,
Yes, I am Jessa Barnard. I'm the executive director of the Vermont Medical Society. And we, as a sort of a informal collective of healthcare provider organizations, started working together. In fact, we were kind of born across the hall in the final days before the legislature shut down and the whole state shut down due to COVID. We all huddled in that room for hours, working with some of you to try to come up with some of these protections in the first place. And then we continued meeting, I think at one point, it might have even been daily, then a couple times a week, and then weekly, but we still are meeting. And thank you to Jill Olson, with Home Health and Hospice has been really coordinating us, and we've stayed in touch. Issues cross our associations. So it is the Vermont Medical Society, Vermont Healthcare Association, Vermont Association of Hospitals and Health Systems, VNAs of Vermont, Bi-State Primary Care Association, Vermont Care Partners, Health First Independent Practice Association, Vermont State Dental Society, Vermont Association of the Area Agencies on Aging, and the Vermont Association of Adult Days. So pretty broad. We cover pretty much all the healthcare and providers. And again, we come together with shared interests. These bill progressions have tended to be where we have worked together the most closely, but now it's turned into a great partnership on even other bills outside this context, where if we can help support, help share information or give joint testimony, we try to do so.
Great.
So that's who we are and how we got here.
I just have a punctuation question, just because I'm being dumb. On your list, it says Vermont Care Partners : which to me means that the following group is part of Vermont Care Partners, but that's not true.
That
That is true. Okay, so that's what I'm trying to understand. So how far, all that group,
So then it ends after Vermont Council. That is a.
Yes, Vermont Care
That is
Partners.
Julie Tesler.
Yes.
They have a,
Vermont Care Partners : Vermont Council is one thing,
That's one
and then all the rest of them are different.
yes,
Sorry, thank
No.
you. I appreciate that.
good question. Jill, do you want to introduce?
Yes, good morning. I'm Jill Olson. I'm the executive director of the VNAs of Vermont. Okay.
So we'll just start with the ones that we have any opinion on.
Yeah.
Want to continue. How about that?
Yeah, and I think Jess and I will be able to pretty quickly figure out which of us is talking about which thing. I also want to just note, we have Laura Pelosi in the room and Devin is on Zoom from the Hospital Association. And I think there's going to be a few where we may need her help. And I can tell you that we found this confusing too, and we helped to write the bill. So part of it is like the section numbers are kind of complicated, but also there's just a lot of different elements of policy. And so it's just, there's a lot to put our heads around.
so let's plan on taking one at a time,
Okay.
slowly, to make sure we're all on the same page.
Okay.
Just go from there.
Okay. I also just wanted to, I feel sentimental about this bill, which I know sounds very strange. But this was really an incredible moment to have a lot of really awesome people come together and try to figure out, and we figured it out pretty fast, all the things that needed to be changed. Lauren was a huge part of that. David Hurley, he was on the phone with us on those early days. And then Jen did some kind of like drafting magic. I mean, I can only describe it as magic because we just said all these things need to change. We didn't even find all the statutory references and suddenly there was this bill. I mean, we did it in 2 days. It was unbelievable. Yeah.
Great coming together.
Okay, so the first one is allowing AHS some authority to modify the various rules that exist. The list isn't there, but there's many of the provider groups are covered by a specific, either a licensing rule, home health agencies have a designation rule. And we do want to allow AHS to keep this authority for one more year. I think actually home health may be the only one using this authority or working under this authority. We have a designation rule that essentially doesn't allow for us
says allowed to expire. So you're changing that?
No, I'm on 4, sorry.
Oh, so, yeah.
You
we wanna-
must have skipped down.
So
Sorry.
just the ones we want to continue.
Yes,
Unless
yes.
you want us to go slower.
I
Any of
apologize.
the ones above
So
that.
just what row you're on each one would be helpful.
So I'm talking about
one that Jen went through is the first row on page 2.
Yeah, okay, so Jessa has Jen's version.
Great.
And I have our version.
Okay.
So hopefully between us,
We'll get there.
keep you on track. I apologize for being confusing. So home health, essentially our designation rule has no flexibility or allowance for a workforce crisis. It does not have any way for us to prioritize patients. It's essentially says we have to take absolutely everybody, which is what we want to do. But there are times when we cannot safely take a patient onto home health service as an agency because there are no nurses, for example. And then Choices for Care has a sort of whole other, it's a whole other thing. So we have a temporary waiver right now. And what we're working on with Dale is figuring out what permanent changes might need to be made to the rule, which would obviously bring in stakeholders. So it would need to be a full process, but we just haven't had time to complete that process. And so we're just asking for this to be extended so that the full rulemaking process with stakeholders could take place.
Okay. So we will hear from AHS as well.
This is the bottom row
Yeah,
here.
yeah.
Okay, I'm
Yeah.
having trouble coordinating it with the other.
Here.
So it's the top row on page
Worse.
2.
Page 2 says Act 91, Section 4.
Sorry.
Yes, it is
Yes.
Act 91, Section 4.
Yeah,
It
so,
says Act 85.
yeah, so let me explain what we
I think what we're gonna need to do, sorry, Jill, can we use Jen's?
Yeah.
Yes.
version?
That's right.
That would be a lot better.
Can we put Jen's version up on the screen or?
Comment, share.
Yes,
comments.
we can do
Yes,
that.
let's do that.
I don't have Jen's version in my
So
Adobe,
we can take everything off the screen
okay?
and just look at Jen's version on your computer, Jessa.
Go to our website.
Or go to our website.
Right, it's on the website. Or I can send
Good
it.
point.
Okay, if I go to the website, you're gonna see all the shopping I was doing this morning. Need a new coat.
Play the website.
Yes, but I mean, it's like,
Can you-
when I hit when I hit that app, it is going to show you
Jill, you
that.
can stop.
Actually, let me
Stop sharing.
Yeah,
Right.
good idea.
Yeah, there we go.
Did you get milk?
Eggs too.
Okay, there we go,
So
okay.
let's go. Sorry, let's just hold on here, everyone.
And eventually we can combine, if helpful, we could put it in one document. We just-
I don't worry about my shopping. I worry about my daughters texting me while I'm.
Well, there's that too. I think I'm on Do Not Disturb.
And maybe while Jill's pulling this up, the next row is about the Green Mountain Care Board flexibilities. And I think this is actually, I believe we have a change actually from what this reflects, what Jen's chart reflects after some further internal discussion. So if we could maybe pull up, there she is, if Devin could speak to the Green Mountain.
So I don't know where you
Okay, so now we're all on Jen's,
Two.
but
I'm there.
page 2 of Jen's, the second row.
Second row, allowing the Green Mountain Care Board to waive or permit variances from laws, guidance, and standards.
Okay, so the most bottom thing that Jen did says a section, so if we could use her sections, then that would be orienting.
So where it says Act 91, Section 5.
Right. That's helpful, thank you.
Okay.
Devin?
Hi, Devin Green, Vermont Association of Hospitals and Health Systems. And yes, I think what I'd like to do for today, if that's okay with the committee, is leave this as a placeholder and try to get agreed upon language with the Green Mountain Care Board. I think what we're trying to do here is given where we are with capacity, I think we had 4 ICU beds available 2 days ago. I think we'd just like some flexibility perhaps in the certificate of need process and other areas to continue to respond to what's happening in healthcare. So I will work with the Green Mountain Care Board and try to get language back to you.
Okay, wonderful. So we'll put that as a placeholder for now. Great. So page 2.
Here, middle of page 2. Just did the Green Mountain Care Board. So now you're under DEVA, which says Act 2002, Act 91, Section 6.
Great.
So this goes a little bit hand in hand with some of the licensure pieces we'll get to in lower rows. But to become a provider in Vermont, providing on the ground care, you need to be both licensed by your licensing board. And then also, typically, to be helpful, you need to be able to bill for those services, which means being credentialed with payers, DIVA for Medicaid, and then private payers. Credentialing can, and we'll get, when we talk about licensing, that we can talk about how sort of that can be a very time consuming process. The full, official licensure process can take weeks, months in many cases. Credentialing can as well. They require things like original proof of where you trained, in some instances your birth certificate, all of your malpractice history, your malpractice coverage. It's a big packet of information. And many entities right now don't have the time to wait for that. The long-term care settings are needing to get medical directors in like day to day. Nurses need to, we have people coming in from out of state to fill temporary needs, physicians, nurses. And so what this one row here asks DIVA for Medicaid and then DFR for the commercial insurers to direct health insurers to relax credentialing requirements. And we'll talk again when we get to the licensing pieces. Another challenge has been there's sort of this two-step process. You need to be licensed to get credentialed, because often for credentialing, you need to show you are licensed in Vermont. So some of the other flexibilities we've allowed, like deeming of licensure, if you're licensed in good standing in another state, the payers have said that's not good enough. You need a Vermont license number. So when we get to the licensing section, you'll see we have another suggestion around directing payers to consider being deemed licensed in Vermont sufficient for credentialing purposes. What we are asking for in this section itself is to simply extend directing the payers to be able to relax their credentialing requirements, again, to partner. Yeah, you're here licensed, but if you can't bill for those services, it's basically not useful to be licensed in the Vermont state.
Go ahead, Art.
Is there any thought or talk about making something like that permanent?
So we have, and we'll get, again, when we get at least to the licensing piece, we'll talk more about that. We've been having a lot of conversations with OPR and the Board of Medical Practice about what they are. And Lauren and David can talk about ways they do have some permanent flexibilities. And there's been a lot of work in that regard. So some of the reasons we're not asking here to make things permanent, but just to extend for another year, is to make sure all of those permanent pieces can be put in place. Whether it's some changes in rulemaking or in the case of OPR, some more educational efforts to clinicians about more expedited pathways that are already available that people may not know they can take advantage of. Around credentialing, I'd probably have to put a little more thought into it. Would there be ways we could speed up credentialing long-term? Probably. But at least for the next year, we're saying at least allow this to, as we work on some of those more permanent pieces, continue the credentialing piece.
And when I hear these words, I'm thinking that the reason for this credentialing is a safety issue for folks. Have we run into any problems with providers that have relaxed credentialing? Treating patients or.
I am not aware, and again, this is on the payer side, so you would have to ask,
okay.
I think, DIVA and the payers that. In fact, what I would encourage you to perhaps ask is, have they used this flexibility at all? Because this is at least for the private insurers, it's more of an allowing them to relax credentialing. And I am, in my experience, they have not actually been using this authority. And so even though the licensing piece is sped up, the credentialing is not sped up. So that has been a continued barrier to getting folks in on short notice.
Okay, so they haven't used it even though they have the authority.
That's my understanding.
Okay, thank you.
And just to make one more comment about credentialing, credentialing is something we have to do. That all of the boards, anybody who's has any kind of accrediting board is going to have a credentialing requirement, so that health insurers have to do credentialing, health providers have to do credentialing. We have masters other than state law that require credentialing. So there's ways to streamline it, but there's no way to make it go away entirely. Yeah.
Tabor has a question.
Yeah, I have a little bit of a problem with the no opinion phrase.
So it's the Board of Medical Practice, and probably because they do licensing, not credentialing.
Right.
So they do have opinions on the licensure pieces, but on the insurer credentialing, it's just not what they do.
Okay.
I'm assuming you can, David.
And David will be here, yeah, so maybe we'll keep scrolling. And I just want to say one more thing I think this is probably in everyone's mind, but in some ways what happened when we originally built this bill was we assumed we were going to have a massive workforce shortage right away. And we did, and when people would get sick, we would have that kind of problem. But in some ways, we're actually dealing with a much more significant situation now. It didn't happen as fast as we thought. And so in many ways, this is what we're grappling with now, is where we're left.
Right. So we have to pause.
Okay.
We need to manage some time of some of our witnesses. So we're going to make this even more confusing.
Can I open another document? Can Laura open her computer over there?
Can we go to the lines that require Board of Medical Practice to have input? Then we're going to go to the rows that have OPR to have input, and then we will come back to all the others.
Okay. Jessica,
I will do my best.
You can figure
I
out
will try to do
which
this, but
thing requires Board of Medical Practice?
Yes, let's see if we can get to. Sorry, I think it's the licensing pieces are a fair amount lower, but actually it's a good segue from the credentialing, so that makes sense. I think we are next on Jen's chart, top of page 5.
That's where I think we are too.
2020 Act 91, Section 17.
What about 12?
Page 5.
Sorry, what about which?
What about 12?
That's
That's
Human
middle.
Services. So is everyone around the table? Good, we're on page 5. Come back to that. Okay. So we'll have you all talk about it, and then we'll bring David in and then we'll just keep going back and forth.
And sorry for I'm trying.
No, please take your time.
So, so this is the piece about the licensing. There's an OPR chunk and a Board of Medical Practice chunk just based on the professional type. And the section we would like to see extended so this is the deeming of a healthcare professional who is licensed, certified, or registered in another state in good standing. So what we have in place is for up to 6 months, if they are a part of a licensed facility working in person in Vermont, they can be considered licensed if they're in good standing in another state. We would like for the Board of Medical Practice and OPR to have this extended for 1 more year to March 31st, 2024. For OPR, and Lauren can talk more about this, we've had some conversations with OPR. It's really about more time to share what they are, educate professionals about more expedited pathways that are already available, and also to implement some other flexibilities that I don't think they need statutory authority to do, but take some time to implement. For the Board of Medical Practice, it would give us some time to work with them and for them to work on the language. We also suggest adding, and the full language is not in your chart, but it is in our chart, is basically asking the board to have some time to work on options for streamlining and modernizing the licensure process. So just some examples, and they're aware of a lot of these already, but requiring an original birth certificate. So if we have somebody in a some states, it's very hard to do that. Some in foreign countries, it's even harder to do that. So are there alternatives there? We know, and the board is well aware, there are some delays with really being able to make the interstate medical licensure compact operational for Vermont licensed physicians. So what are the next steps with that? So that is why we would like the extension and also some language around the Board of Medical Practice reporting back on streamlining the licensure process. This is also where we would like to see the language added that says deeming is the equivalent of licensure and should be considered sufficient by payers and healthcare facilities to meet credentialing and enrollment licensure requirements. Because that's really what's been holding up, I think, this allowing more flexibility on the credentialing side? Is it if they're saying, well, sure, for licensure purposes, you can practice here, but we want you to, we need a Vermont license number. It really doesn't actually help people get on the ground working in Vermont more quickly.
Because they're licensed, but they can't bill.
They can't
They can't bill.
Or they can't admit patient, like, so say if you're here for the hospital that needs to be credentialed, you couldn't admit patients, you couldn't bill. I want to point out, I believe, am I in the right place, that this also, sorry, is this the section? Oh, yeah, so the existing underlying language also references being deemed for telehealth purposes, and I see Jen has that in her chart as struck, and we are comfortable not continuing this flexibility for those located in Vermont and are just practicing via telehealth. We're only asking for the people who are in a licensed facility in Vermont for this to be extended.
Okay, so I'm gonna just restate what you said to make sure we all understand. So you're asking specifically in this one for a healthcare professional who does not reside in Vermont to be deemed as a healthcare professional in Vermont to be able to work for 6 months if they have a valid license.
And if they come in state.
They come to work here. Okay. So why don't we start with David? Are you around, David?
Madam Chair, can I just say, so
Sure.
we're essentially doing a couple of things here. We're part of what we're doing is extending a flexibility that we've had since 2020. And some of what we're doing is making some recommendations. So this is maybe one of the most complicated ones we're going to do. They're not going to be this hard, but that it is a blend. And OPR has done some really nice work in creating some permanent flexibilities for nurses that we would like to see for other professions, and we need to get everybody up to speed on them.
Okay, so is it possible for you to minimize your screen so we can see David without causing a
Yes.
problem?
Yes.
And then Art, you have a question before we go to David?
Yeah, I posed basically the same question as before. Is there talk of this being? Only because, I hate to see, we're already short healthcare workers. We can't afford to lose one person
Absolutely.
fooling around with the stuff.
We entirely agree, and I think that's where we were really appreciative. Lauren came to one of our coalition meetings a while back and walked us through what OPR, Office of Professional Regulation, has done to create. I wouldn't say it's exactly this, but it's
Right.
other pathways that are more flexible and faster.
Okay.
And so that is permanent. It's just that it's not
It
fully
might not be
implemented.
just this,
Yes.
correct. Okay.
Yeah.
Yeah.
I'm looking at Lauren's sign. Okay, I'm just making sure.
So David and Lauren, if you're okay, we're just gonna kind of tag team each of these as we go. So we stay on one section. So David, we'll hear from you, and then we'll go to Lauren if you don't mind testifying from the corner.
I do not.
Okay, great. David.
I can even come more out of the corner.
David.
Thank you for working around my schedule and getting me on. I'm David Hurley. I'm the Executive Director of the Board of Medical Practice. And happy to join you here today. I do want to say one thing in general. I heard somebody express concern about the use of the term no opinion on several of the sections. And that's just, the board has certain regulatory authority, and these were on the matters that are just, not what the board does with regulating physicians and a number of other professions. We just didn't think it appropriate to weigh in on those. And so I didn't express any opinion on those, and it wasn't meant to be, disrespectful of the committee or lazy about dealing with this.
It wasn't taken that way. Thank you. So thoughts on this Act 91, Section 17?
Yes, well, the board did consider this at their monthly meeting, took place last Wednesday on the 1st. And they did support extension of Section 17 for practice in a licensed facility. And that includes hospitals and all other forms of licensed healthcare facilities and FQHCs, the federally qualified health centers. And the board supports that. They did not include extension of the telehealth provision. And the reason for that was not because they don't see merit in having ongoing flexibility for telehealth, but we already have that in the law.
Right.
There are other acts passed that, we have temporary telehealth registration that's effective through the summer, and then we go into a reduced fee telehealth registration or the option of a telehealth license. I spoke with Lauren about this, and I'll let her speak for herself, but I appreciate her views on what works for them, and I don't want to get in the way of them getting what they need. So that the board didn't express anything about the telehealth because they thought it was already covered, but I wouldn't oppose extension of that. Though I think, at some point we need to start working back toward away from what we were doing during the emergency and getting back to established procedures. So maybe less than a year, I think, but I'll let Lauren.
And David, I'm going to interrupt you. For the telehealth piece, that's already out, and we're not asking for that to continue. So we agree with you that I think what we put in place last year around telehealth is what we need to stay with. So thank you for that. What about the addition of the report requirement to look at how Board of Medical Practice and OPR, so we'll talk to Lauren in a moment, can facilitate changes?
I'd welcome that. We were, before this came up, I've been working on, reviewing everything that we require. And there's been a lot of evolution in the way that the whole, they call it the House of Medicine, all the different players are interacting and sharing information. And I don't want to say too much and raise expectations on for Jessa and others, but we are, looking at, there's some really exciting stuff going on with the development of these secure information exchanges. They're referred to as APIs, and updating our system to allow, rather than forcing applicants to go out and get every single piece of paper, if there are holders of this information that are worthy of reliance, that are certified as being the equivalent of primary source verification, we could just suck that information right into our system as soon as they start the application process and eliminate a lot of the groundwork that they need to do to get their package together. We, whenever we talk about how long it takes to get a license, it's from the time the applicant does what they need to do, it's a maximum normally of 2 to 4 weeks, unless they have some adverse history that needs to be scrutinized and discussed by board members. But it can take some time for people who have challenges in assembling the documentation. And so, we are happy to work on that, and we are looking at that.
Okay, so any other comments on this section from the Board of Medical Practice?
No.
Lauren, would you like to speak for OPR?
Lauren, do you want to, I'll just come, just so that people, Lauren, do you want to sit here? Sure. I just want to make sure that people watching can see me for the value that I bring.
Welcome back.
Thank you.
Senator Lauren.
Senator Lauren, exactly.
I know.
What's going on here?
Other duo.
Right.
For the record, Lauren Hibbert, Deputy Secretary of State. Thank you so much for having me this morning. Specifically on Section 17, our recommendation has been, and I just want to confirm with Legislative Counsel, that her understanding of the telehealth section is that the people who are currently registered, we can extend through July. Because I was reading the law that we passed last year and this law and thinking that we had a gap between March 31st.
I think we addressed the gap.
I think we did.
Okay, I just wanted to confirm. Maybe it's not in the law and it was session law, and that's why I didn't see it.
put provisions in.
So while Jen's looking at that, let's just bring everyone up to speed on the telehealth legislation we passed. And I'm going to do a quick one. If you want to add, please do. But basically, we put in place a temporary registration period where we allowed people to get just a registration, right? So I'm practicing telehealth during COVID and they had to let OPR know who they were. And that went through what was the dates for that?
So what the bill 85 was through March 31st, and what Jen Carby just clarified for me is we did do some session law.
Okay.
Thank you so much. Extending it through June 30th. So I don't think this committee needs to do anything in relationship to the telehealth provisions of 17.
Okay, then we'll talk about telehealth another day.
But I do want to just tell this committee that our office has registered 2,195 professionals doing telehealth since April of 2020. And 2,177 are currently active. So this is being actively used by professionals. We will transition them, help them get informed on how to apply for the telehealth license and get that moving as quickly as possible.
That's great, Lauren. Go ahead, Alyssa.
Did you say 22,000?
2,200.
2,200 are currently, but how many did you say had?
2195.
Okay.
Yeah.
Thank you.
So what we know is that people started doing it at the beginning of COVID and have kept re-upping it. And so these are the population that we anticipate will be part of the telehealth registration.
Right.
Just a question on that, Lauren. 2195, not above what we typically get, is it, or?
Well, I think what is truly remarkable about this work is we have never done it before. So there's nothing typical. So, I just want to say, and I sort of just jumped.
No background, yeah. These are people that want to work in telehealth.
These are out-of-state folks who want to provide telehealth services to Vermonters.
Oh, wonderful. Thank you.
And
Thank you for
we
clarifying.
created a very creative pathway to enable them to do that during COVID. And I jumped right into being goofy about sitting in this chair. And I neglected to just say the huge debt of gratitude that we all should have to this committee, to the coalition provider group, to legislative council. I also feel very attached to this legislation. And it's a way that I've been able to give back to the state I love. So thank you for letting me do this. It enabled healthcare, and it's something we all should be very proud of. On section 17, as it relates to facility registrations, we would prefer, we would like this provision to extend through 2023.
Okay.
2024.
Okay.
We would prefer if it was limited to professions where we do not have a provisional path. We have a provisional path now in nursing. We just expanded it to OT, PT, rad techs. So we currently have
Right.
radiology technicians. So they're the folks who do x-rays, CAT scans, PTs, all of that. Right now we have 1,017 facility registrations that we have been issued since the beginning of the pandemic. And right now, 725 healthcare providers are using this provision. We also are using the provisional license. And just to recap the provisional license, that allows the Office of Professional Regulation to issue a provisional license if we're waiting for a background check or a verification from another state. It gets them in the path for the full license. We currently have 396 active provisional licenses, but we've issued a total of 848 since we went live with that provision in the beginning of September, I believe. And currently, right now, we have 77 APRN provisionals, 382 LNA provisionals. I'm sorry, this is the total that we've issued on whole. 77 APRN, 382 LNAs, 46 LPNs, 342 RNs, and we just got our first PT because we just went live with it last week. So we would really prefer the provisional path to be utilized. I've talked with the Provider Commission Coalition about this because that way our revenue is not impacted. All of these COVID flexibilities, we have not been collecting fees. We have had a revenue loss. We did go through the General Assembly and get a one-time allocation last year. I don't know whether that's going to be a path for us this year. It wasn't the easiest lift, so it's not a given that we'll have it again. And the other reason is we're talking about people who are qualified to practice here that need this flexibility. That's why they're being hired by the facilities. So we'd like to get them into the path and minimize our pathways because what we're seeing is it's confusing, it's hard to explain. And so we would like the facility registration to just be limited to those professions where we don't have the provisional path. Now, the issue with that is we're going to be constantly changing and increasing the number of professions where we have provisional path.
Right.
And so that's not easy to write into the bill. But that is easy for our system to accommodate and for our staff to talk to folks about.
Okay.
I have a question about what does it mean when it says provide services as a volunteer member?
Of the medical corps,
Yeah.
through, and David may be a better witness to speak to this, but through the Department of Health, there is a voluntary medical corps, I believe is what corps. And they have, they are not paid and they go into facilities to provide medical care. And the deeming allowed volunteers from other states to be part of that corps.
And the reason I asked the question is, what does that do in terms of liability?
I believe, I'm not the right person to answer that question, but I believe the facility is covering the liability of the volunteers.
And we just had Devin and David pop up on our screen. Gotta love Zoom. So David, we'll let you go first and then Devin will go to you.
Sure. The Medical Reserve Corps is a program that is supported and encouraged by HHS, and I think most states have it now. And it's relatively new, and 10 years or so, maybe a little bit more. And it allows practitioners to come back and provide some service. Most of the Medical Reserve Corps physicians and PAs who we saw coming to get a license in this way, they were going to be providing COVID shots. They're not actually going into healthcare facilities and providing direct care for the most part. They're working with Department of Health emergency response efforts. And I do want to know, for the record, while everybody's here, I believe that Jessa Barnard's father was one of our first people to get a license using the provision that allowed for the medical reserve. So thank you, Jessa, to your father.
Devin?
Devin Green, Vermont Association of Hospitals and Health Systems. And I was just going to add, my understanding is the liability is through the liability insurance is through the, and workers' comp is through the Medical Reserve Corps program.
Good.
I think that's correct also.
Great. Okay, so I think what I would like to do is at some point come back to the coalition to talk about the provisional piece, but due to timing, can we keep going? On the, stay where you are, keep going. So let's go to, I'm sorry, were you done with this section? Were you done?
I am done with this section.
Okay, perfect, stay right there. So now we're gonna go to page 7, which is Act 91, Section 20.
You want me to put it back up?
That would, no, because we need David.
Oh,
So
okay.
This is the one, the Provider Coalition is deferring to OPR and Board of Medical Practice. And this is around allowing remote meetings. So OPR and Board of Medical Practice, if they find that the boards cannot reasonably, safely, and expeditiously convene a quorum, that they may exercise full powers and authorities of the respective boards, including disciplinary records authority. And I'll let David speak for himself, but he indicated here that it's not really needed anymore because remote meetings are the norm. But just to confirm, David, you would be okay with this expiring?
That's correct. I mean, unless we had a new, different kind of emergency that interfered with the ability to connect with our members using the internet or telephones, then we haven't used it, and I don't think we will.
Okay.
I concur with David. I used this provision quite a bit in the beginning of the pandemic before we had set up our administrative rules for electronic hearings.
Okay.
But we do not need it anymore.
Great, so we will let that one expire. So then the next one for the two of you again is the very next row on page 7, section 21 of Act 91. OPR Director and Commissioner of Health may issue orders governing regulatory professional activities and practices as needed to protect public health, safety, and welfare. And the notes from the Board of Medical Practice was allowed to expire.
We haven't had occasion to use that.
Okay.
And I think actually, if it came down to it, if there was an emergency, the Commissioner of Health has certain emergency powers anyway that are separate. We had at the time just differences in our structure. It seemed more appropriate for that to be with the commissioner. You'll notice that it was with OPR. It wasn't with their boards. It was with the director of OPR. And the commissioner is the one up for us, so.
Okay, great. Lauren?
I again concur with David. This is a provision that we used, but we are not using it anymore.
Okay, Leslie, you have a question?
Well, I just want to understand where it sits if it doesn't sit with you guys. Like who protects public health, safety, and welfare if it doesn't sit with the two of you?
So I agree with David that I think the commissioner does have some authority to do this activity, but also I think that our current disciplinary process would work if there was a significant problem. We would do an emergency suspension of a provider's license if there was something this egregious, and that would work. But this was such a useful provision for us in the beginning, and it was brilliant of the Provider Coalition, this committee, and stakeholders to include it because we needed it, because we couldn't use our current process because we weren't meeting in that way. So the current process, disciplinary process would work. And I agree with David that the commissioner could also engage in sort of a cease and desist order. We also have worked with the Attorney General's office, and I think they could as well.
It's amazing what we've learned along the way.
It's amazing what we've learned.
Okay, so let's keep going. We're doing great. So page 8, first row, Act 91, Section 26. The Provider Coalition has asked that this be extended through March 31st of 2024. It's to extent permitted by federal law or guidance on enforcement discretion allows waiver of telehealth requirements relating to HIPAA compliant connections. David, it says you do not oppose the extension. Did you have any other thoughts or comments you wanted to make?
No, just I'm having trouble following because I got a chart from you and it has different page numbers. It only goes up to page 5. But that
was the original request from the coalition. I apologize. Yes.
No, I don't have an issue with that one.
Okay.
We also do not have an issue with that one.
Okay.
I believe that the telehealth rules that are in process of about to be filed do address this, but that's the ongoing standard, and this flexibility can layer on top of those rules and waive it while it's in effect.
Great. Okay, so the next one, David, I'll read it since you're looking at a different chart. So for us, if we're on the same page 8, row 3, under the shaded row, it's Act 140, Section 15. Again, the Provider Coalition would like us to extend it through the March 31st, 2024. It's for the Board of Medical Practice or its executive director may issue to individual licensed as a physician, physician assistant, or podiatrist in another jurisdiction a temporary license to practice in Vermont until not later than April 1st, 2023. And the Board of Medical Practice or its executive director may waive requirements, including scope of practice requirements for physician assistants, may impose limitations or conditions when granting waiver. David.
Yes, and again, the board did not include this in their motion where they supported the extension of the deeming to work in licensed facilities and FQHCs, but I'm not going to oppose it. We would prefer to see the use of deeming, and again, the board takes seriously its obligation to screen people who are coming to provide practice, and the only way to do that is to get their complete history. And does it happen a lot? Do we get a lot of people who are trying to hide adverse history and get a license that the board might deny? No, I don't see it every day, but I don't know how much you've been following in the news. It's just come out that there were tens of thousands of nurses got bogus licenses because they had bogus degrees in Florida. So, there are reasons why we need to go about our business and in the normal course of business. And the board went along with the extreme measures proposed in COVID and all the uncertainty about our ability to meet healthcare needs. I realize that the system is under stress now, but at some point, we need to get back to screening things and as the board does.
Okay. Art?
Is there any screening that took place on this item? Did we, it says you can issue a license for a physician's assistant for somebody in another jurisdiction, but did the person call, say, I want to work in Vermont, and said, oh, okay, and put him on the list and he's done, or was there any screening? Well,
they have to show that they're good standing in the jurisdiction that they're relying on is their, where they're currently practicing.
All right.
But
so they do have to show that they have a license there.
Yes.
Yeah.
And that it's in good standing.
Yeah.
Yeah.
So I hate to ask this question, but what more do we want from these people on a permanent basis?
Well, on a permanent basis, first of all, Vermont's standards are higher than some jurisdictions, and there are jurisdictions that have shockingly low bars that have, Vermont is typically in all the measurements of healthcare workforce, like with physicians and primary care, we're usually in the top 5 states in the country for being in the best position. Typically the states that are in the bottom 5 or the bottom 10 have much lower standards. So that's one thing, is we enforce our standards, and there's reasons for that. There are studies that show that people who have fewer years of graduate medical education tend to have higher rates of malpractice and higher rates of misconduct. We don't have the highest requirements for passing the United States medical licensing exam, but there's some states that have very lax requirements, and so frankly, it's a quality issue, and the board works hard to set these standards that we follow. So it's maintaining our standards and not the standards of the states that have the lowest requirements. So that's one element of it. And the other is we find on a not irregular basis, we find that in some states, they just aren't careful in the way they do their work. And we find people who do have, they have faked their qualifications, or they've not been disciplined in other states for significant unprofessional conduct. And so, the board's given the assignment to protect patients in Vermont, and they take it seriously.
Thank you.
Laura, did you have anything to add?
This section does not involve OPR.
Okay, great. So I believe, David, that we have touched on all aspects of what would fall under Board of Medical Practice. I'm looking to the coalition to confirm that as well. But David, did you have anything else you wanted to testify on today?
Well, I would just mention the buprenorphine one. The board, does that's practice issues are within the board's scope, but we just didn't have time to talk about that at our meeting last week. I did talk to the commissioner and the buprenorphine program director, and I would really recommend that you touch base with them, because they're really the ones who are more in a position to set policy on those matters.
Okay, and that will be Human Services. Leslie, did you have a question?
Well, one of my questions was on buprenorphine, but I guess you're saying, yeah, we're not going to do it
We're
here.
not doing that one.
Got it.
Great, Lauren.
I don't believe that I have provided testimony on
Yes.
sections. It's on page 6. It's of Act 81. It was section 1, the former healthcare professions. Former healthcare professional who's retired, not more than 3 years, inactive, not more than 3 years. We agree with the Board of Medical Practice and would like that to expire.
Okay, so on that one, everyone's on the same page. Okay,
Can I ask a question?
please do.
I have a question on that, and why we would not kind of make that permanent. Why wouldn't we, if we've got professionals that have retired and want to come back and they qualify, why wouldn't we tap into that?
Yeah, I think it's a great question. So for the majority of our professions, we do have a pathway back from retirement already written into the statute and rules. This was just like a uniform piece of sandpaper that made it all consistent, right? So we would like to go back to what we've previously established in statutes or administrative rules of what training is required. Frequently, there needs to be some training. We're talking about professions that are changing rapidly. So we want to make sure that if you retired 3 years ago, of course, we want you to come back into the profession, but you might need to do a reentry program if it's more than 5 years ago that you were a nurse. And I don't have all all of them memorized what you need to do, but we have pathways back in statutes and rules. And I think Vermont has already, before this these provisions went into effect, was already contemplating people who had retired but then wanted to come back. And we have pathways for that.
Do we have any sense of how many came back under this provision in Vermont?
Yes.
That'd be an interesting figure to know.
We do. I don't have them.
Okay, yeah, no, that's
But
fine.
we do. What I can tell you is they're not being used now, because what happened was people came back and then they obtained the requisite practice hours, and now they just have a traditional license. They came back during COVID as an active public service, and they've stayed or they've left. But the people who've stayed now just qualify for a Vermont license,
Okay,
particularly in nursing.
so they're not doing anything now, pretty much.
No, I think those
No.
folks who came back from retirement are now working
Are
in our
practicing
facilities. And I'm seeing Jill nod, so, and Laura nod. So I know that people came out of retirement as a result, a response to the COVID pandemic, and then decided to stay employed.
Well, and understand, the reason for my questioning is I hate to see these people leave the system, an already stressed system, and make it more stressful by saying, hey, I'm not gonna go through the training. I'm not gonna bother with that. I'll just retire and go my merry way. And I didn't know whether I let this go even a couple of years to, I don't know, just a thought occurred to me that maybe we could massage that a little so these folks would stay with us.
Jill?
Just a thought.
What I heard from members was most of them were using people coming out of retirement in a very limited capacity, like for vaccinations mostly. So when we were really gearing up to vaccinate people at home. But for the most part, it was actually uncomfortable for the organizations under their own liability and sort of clinical concerns to have people working who were not, who had been retired for a while. But one of the things that I really appreciated, you'll notice in this bill, it's all time delimited. And at first, we had some of this stuff tied to public health emergency. And it was actually Lauren's brilliant idea to make it date certain so that people also who came back from retirement and wanted to stick around knew this is my deadline to get all my clinical hours in and take care of all of the requirements, rather than it sort of evaporating suddenly with a public health emergency that could have expired at any time. So, yeah. So I think for those reasons and some of the other provisional pathways, we felt like at this moment in time, we don't need it.
So Lauren, was there anything else that we needed to touch on for yours?
Only other piece that I think I would like to provide testimony on is on page 8, section 3 of 85, the very bottom piece, the sunset on pharmacist authority to order and administer COVID tests. I don't have a strong opinion on this section. Jen Carby did mention that that there are pieces moving in the OPR bill related to COVID. However, they are not related to COVID tests. They're related to COVID vaccination. And I have sent a message to David Englander at the Department of Health, but I haven't heard back because I just sent it this morning while sitting in the corner. And or maybe I've heard back, but I don't know.
Okay.
And I don't know whether the Department of Health sees pharmacies being part of the COVID testing landscape in the foreseeable future. I do know that in terms of COVID vaccinations, I think the Department of Health supports pharmacists continuing to be able to provide COVID vaccinations. And I'll just note that with President Biden telling the public that he is going to lift the public state of emergency in May, a lot of the provisions that have enabled pharmacies to do COVID activities, vaccinations, testing, and not just pharmacists, but also pharmacy technicians, is expiring at the end of, in the middle of May. And so we're watching this, and that's partly why it's included in the OPR bill, not for pharmacy technicians, but for pharmacists to provide COVID vaccination.
Okay, so we're gonna hold on that until, if you can share, and then we'll bring in BDH if we have to. Mari?
I'd just like to add to that placeholder, knowing pharmacists, many, I think at least half of them are doctorate prepared, are, I think, excellent partners in community healthcare, especially in rural areas. And, this committee bill may not be the place, maybe, but I would like to hear from them, especially about the things that are going to be expiring. And I'd like to hear more from them about how they can be partners to this coalition of healthcare providers. I think they have a lot to offer.
So you're saying in the broader context of the public emergency ending, what do we as
how can we take what we learned during the pandemic to make progress in seeing pharmacists and pharmacies with oversight be active parts of healthcare in our communities, including, this is a bigger picture, but including having possibly small clinics in pharmacies. That's beyond this.
Beyond this bill.
So if I could just say 2 words on that, we have expanded pharmacy scope of practice through an OPR bill 2 years ago, maybe 3 years ago, on clinical prescribing of for pharmacists. And that's the section that we're modifying again. And I anticipate when the bill is released from House GovOps that I'll come here, but it includes, the depot shot, and it includes some other little tune-ups. And if you wanted to hear specifically related to these provisions, I would recommend that you reach out to Theo Kennedy, who represents the Association of Pharmacists.
Yes, we've been chatting.
Okay, good.
Just clarification, if that's okay. So what I'm understanding is you have an OPR bill, and so of course we haven't seen it, but you think it's coming to us.
We won't, Lauren doesn't know that. I mean, that's not her place to say.
Yeah, okay. But what I'm understanding is that this pharmacist authority is going to be embedded in that bill. Is that what I'm hearing?
So not this section identically.
Okay.
Because this section is specific to administering COVID tests and
But you said, okay,
the PCR COVID test, not the rapid one.
okay.
And what is in the OPR bill proposed language that I believe was released today, what is related to ACIP vaccinations, of which the COVID vaccine is one of them, and allowing by state protocol, so that would be the Commissioner of Health writing a protocol for pharmacists on how to administer the vaccine,
Okay.
being able to do that in a pharmacy, and just clarity around that. Some of that's been happening, and we want to provide a little bit more crispness, and that would include the COVID vaccine.
Okay, so vaccines will continue, but the testing will not, if this is what I'm under.
If this is sunsetted, then yes, the COVID, administering the PCR test would not continue in pharmacies. And I'm just not clear what the Department of Health's perspective is on it. And I'm speaking to it only because we regulate the pharmacies and the pharmacists and the pharmacy technicians.
So then my question is, where are those tests? Would that be a VDH question?
We will talk to BBH.
Yeah, so that's where it would go.
Yes.
I'm looking at the path.
Yes.
Thank you.
Okay, so that was all over the place, but I think it came together very well. I know we're not done with the coalition. Thank you, Lauren. David had to leave. Thank you very much. I think what we will do is take if everyone's okay, a 15-minute break and come back and continue reviewing with the coalition their points